We'll be talking about the bowel obstruction, which is a very common issue that we face in palliative care. So today we'll be focusing more on malignant bowel obstruction. And we have already heard from Dr. Rutula a few sessions back about non-cancer illnesses in palliative care. So Dr. Rutula will be talking about the malignant bowel obstruction today. This was a last minute request to Dr. Rutula, and thank you so much for telling yes and agreeing to be part of this program, Rutula. Thank you so much, and over to you.
Thank you for having me back. I hope you can hear me. There's a bit of disturbance in the internet connection, so I'm hoping that you are able to hear me.
Yeah, you can switch off your video if you feel, I mean, there is a slight lag in what you're telling.
Yes, so I'll just switch off my video for that purpose only.
Sure.
Is it better now?
Yes, we can hear you.
Yeah. Okay. So could you please share my screen, like share the PPT, then we'll start.
Sure.
Thank you. So today, as I'm already said, that we'll be discussing regarding bowel obstruction. Next slide, please. So I just want to say that, we will also cover a bit of constipation because it is kind of prelude to malignant bowel obstruction. So we'll discuss briefly regarding constipation as well, and then we'll go on to malignant bowel obstruction. A big shout out to Dr. Frank Ferris for some of the inspirations for these slides. So I've taken a lot of pictures from his presentation, so I'm really grateful for him. Next slide, please. So what is constipation? Can anyone tell me what do you mean by constipation? Anyone? Just unmute and just say. No one? Okay, now next slide. We'll just discuss. Passing hard stools, yes, exactly. So basically difficult, infrequent, and incomplete defecation. That is what it means. And not just once or twice, it is persistent over a couple of days maybe, or weeks maybe. Next slide, please. Okay, and so since we are discussing constipation, can anyone tell me what are the main functions of colon? Like, what does it do? What does, like, why is it there? Anyone? Just unmute and say, I'm sorry, it's just a bit of lag, so I'll not be able to read the charts very easily. Water reabsorption is one, yes, very good. Anything else?
Production of fecal matter after the digestion of food, whatever is there, like fibers, yes, or end products of exactly, digestion. Yeah.
Okay, so basically the food content and mixing of it and digest it, post digestion, whatever residual is there. Correct. So basically it stores also. So it's like basics are water reabsorption, then is storage of the food that we've had and mixing the contents, and then as you rightly said, it's whatever you want to excrete out. So that is by with the help of peristalsis and coordinating when it is appropriate to have those reflexes. And so like for example, fight and flight reflex. So you'll not want to go for you won't have time during a crisis situation or a stressful situation. So you need to coordinate with the rest of the body as well if you can or cannot have these functions. Next slide, please. So can you see the next slide? Yeah. So this is just basically the enteric nerve. all the systems in the colon. So basically you have your mucosa, your muscularis mucosa, the submucosa, then your muscles which are in 2 layers, and the serosa, right? So, and the mesenteric plexus. So what happens is, because of the digested food, the bowel loops will dilate, which will trigger the stretch reflexes, which lead to the peristaltic movements and thus helps in defecation. So that is the basic physiology of how the whole process occurs. Next slide, please. So keep this in mind, and we'll go further down how to go about it, right? Then we have the approximate.
Hello, ma'am, we can hear you. Dr. Rutula.
So to just briefly tell you how the whole absorption occurs, like fluid absorption here. So basically, approximately, let's say if you have you intake around 2 liters of fluids orally, and then the addition of your saliva, your gastric secretions, your bile secretions, and pancreatic and intestinal secretions. So the total adds up to around 7 liters. And then the reabsorption of all this basically occurs either in the small intestine, but the majority is in the colon. In the small intestine, and then small proportion in the colon, and and you excrete around 0.1 liter approximately through the anal. So this is the colonic, I'm talking about excretion, not the renal one. Next slide, please. Okay. So next slide. So here we'll discuss, briefly see what is the pathophysiology of constipation. There are various factors that are involved. So it can be psychogenic, which can be, for example, anism, that is, instead of relaxation of the pelvic floor, there is constriction, so the stools cannot pass. Then post-surgery or post-trauma, then that is paralytic ileus, which is actually just to give it a rest and kind of an acute reflex. Then there can be mechanical obstruction, which can be either luminal or extraluminal. Then neurogenic disorders, which is the abnormalities in the plexus and mesenteric plexus in the nervous system of the colon. And certain drugs which may cause constipation, or in overall there is low fiber or low bulk forming substances in the food that we have, or there is a decreased fluid intake that can also lead to constipation. Next slide, please. Next slide. Yeah. So these are the causes that we were discussing, kind of maybe endocrine or metabolic, neurological, anorectal, fissures and strictures, or irritable bowel syndrome also sometimes lead to varied pattern of stool passing of the stool, so and lead to constipation. Then can be psychogenic, as we already said. Then iatrogenic, which are usually drugs or post surgery, but daily and dietary life habits. Next slide, please. So for constipation, the non-pharmacological treatment would be having a fiber-rich diet or increased in fluid intake. You have to have certain amount of physical activity for normal passage of stools. Then if you kind of habituate yourself to a regularized bowel habits, that can also lead for relieving of constipation. So this mostly pertains to foreign countries, because they have like they don't have, usually we go every day, like once every day at least, most of us. But usually in foreign like US or UK, maybe they have they don't have the habit of going every day, and their food habits are also very different from ours. They have a lot of carbohydrates and carbohydrates in their diet instead of fibers and proteins. So that can lead to the constipating pattern in their lifestyle. Next slide, please. Then coming to the pharmacological treatment, certain drugs that can help are usually usually laxatives, though can be bulk forming laxatives or can be surfactant, which are softeners basically so they make passing of the stools easier. There can be osmotic agents which bring in the fluid into the lumen so that it helps in passing the stools. Then stimulant, which increase the peristaltic movements of the peristaltic movements of the colon, and others like pamoras, etc., which are specific if it is opioid induced or it's opioid induced constipation. Next slide, please. So these are a few examples of various laxatives that we said. Usually we would go for either softeners or lubricants and stimulant, combination of two, so that it kind of, you're helping the stools be soft enough to be passed easily, so that you don't have the complications of passing hard stools if you just give stimulants to the patient who has been constipated for, like, let's say 4 or 5 days. The stools will be hard enough to cause fissures afterwards if you just give stimulants. So you need to make sure that you've given softeners or lubricants so that it passes off easily. Next slide, please. So this is briefly just to tell you where the drugs act. So which will act in the small bowel and which will act on the large intestine. So this is just briefly to just let you know. Next slide, please. As I said before, lubricants are basically to ease the passage of stools, and it minimizes the pain. So what the options that are either mineral oil enema or glycerin suppositories, that is used usually, but docusate can also be one of the options. Next slide. For motility, as we said, stimulant. So basically bisacodyl or senna, that is given, and enemas. So Dr. Glycine enema, or you sometimes have to use sucralfate enemas also, but these are usually when there is associated internal bleeding. So it can be used. Next slide, please. So can we just briefly discuss what are the medications which cause constipation? Can anyone tell me which they are? Any examples? You can just give the broad heading also, like I'll say one opioid. Other than that, what are the other agents which cause constipation? Next slide, just go on to next.
Calcium.
Anyone? Opioids, yes. Apart from opioids, what else? So many are there. So you'll have to tell me one at least.
There is a response, GABApentin.
Carbapenem, not so much. No. Have you? Yes, iron tablets. Yes. Antipsychotic medications.
Calcium.
Yes. Calcium channel blockers. Yes. Anything else? Okay, next slide, please. So there is this table fills in, and these are few of the examples of drugs causing constipation. So hopefully this helps later on. Now, next slide, please. So this is just an. Can you see the? Yeah. So this is just a case, a brief, kind of a history, and we'll just discuss what can be the possible management. So a 68-year-old male with gastric cancer, he was admitted for pain, basically acute pain crisis. He was previously at home. He was on these many medications. Next slide. So he was shifted onto injectable morphine, which was a patient-controlled analgesia. And the oral equivalent of morphine was around 70 milligrams. And he is constipated. So the last bowel movement was 3 days ago. So what do you think is the likely cause for constipation here? What do you think? Why does he have constipation? What is the likely cause?
Anyone would like to unmute and talk?
Either unmute or you can just type in the chat also. That's fine.
It is opioid in. Good afternoon, ma'am. Can I answer?
Yes, Dr. Vandana, please.
Yeah, it is. It appears to
Just
be
the cause.
opioid-induced. The cause or the pathophysiology of opioid-induced constipation. It appears to be due to the opioids that the patient is on. Yeah.
Right.
And
Yes.
yeah, please come.
So mostly it was opioid that was causing the constipation here. So what do you think is the so basically he was then later put on various medications. Like next slide, please. So afterwards he was put on laxatives and everything. And 6 months later, he revisited the hospital with suspected ileus. Opioid medications in bowel regime had been titrated as the outpatient post the admission 6 months previous. But constipation has been there on and off since he began the opioid therapy. So next slide, please. Currently, the bowel regimen is he takes Docusate orally twice a day. Senna also again twice a day. He's also on PEG powder QID, and Bisacodyl suppositories are also given SOS. He had been given lactulose and milk of magnesia, but it did not help him that much. So, do you think? What will help here? What do you think Pamoras will help here, like methyl naltrexone? Would that help, or would you give something else? Would you try something else before?
A prokinetic agent can be tried.
Dr. Rutula, are you there?
She's there, but her network is not stable, I think.
Okay, okay.
Prokinetic is already there. That whenever.
Dr. Rutula, your voice is
Do you
breaking.
think methyl nitroxide? Sorry.
Ma'am, your voice is constantly breaking. It's not clear.
So yes, correctly said. It should help. Methyl naltrexone should help here because it mostly looks like opioid-induced constipation. So that should help. Okay, next slide, please. So that now again a different case. She is a 57-year-old female with ovarian cancer, stage 4, is having continuous colic abdominal pain, continuous and colic abdominal pain. There is abdominal distension, no bowel movement since 7 days, and is presenting with nausea and vomiting, which is acute and large volume vomitus with undigested food particle. And usually the pain and the whole complaints are relieved after she vomits. So what do you think is the cause? Is she constipated, or do you think that there is something else that is wrong with the patient? Yes, it looks like obstruction, doesn't it? Like it's maybe like, small bowel obstruction. So correct, that is what we'll suspect. So come next slide, please. So let's just, see how malignant bowel obstruction goes now. Next slide. Yeah. So it is basically caused by the ineffective motility or occlusion of the lumen, bowel lumen, and many times because of various abdominal or pelvic cancers, uh, or if there are peritoneal meds from other pregnancies like lung, breast, or esophagus. Next slide, please. So again, it can be large bowel obstruction or small bowel obstruction. It can be partial obstruction or complete obstruction. And the survival decreases after that. So if it is operable, then still it is around 4 to 6 weeks. But if it is inoperable, multiple level obstruction because of the primary, then it drastically reduces to like 4 to 6 weeks. Next slide, please. So again, back to the case that we saw, it looks like obstruction. So what do you think? It's upper bowel or lower bowel obstruction? Depending on the symptoms that you're seeing, what do you think it is? Where is the obstruction? Upper GI. Yes, it looks like upper GI obstruction. Okay, so just to briefly tell you, next slide, please. So just to briefly see what exactly happens in bowel obstruction. So as you see the flow chart. So let's say if it is partial or complete obstruction, like interruption of transit of the contents in the bowel. Next slide. So what can happen is there is increase in the luminal contents. Just go next till the whole flow chart comes in, so that it's upper niche. Oh, I'm so sorry. It got.
I think maybe format got changed in a different
I think
laptop
so.
probably.
Yeah. Oh, I'm so sorry. the previous one. Yeah. Can you just see the whatever is written? I'm so sorry. The format I think has changed. So basically, what happens is the luminal content increases, which will cause bowel distension. First thing, and also because the lumen is distended, the surface area also increases. So because of the surface there is increased secretions of water and sodium and chloride into the lumen, which in effect will lead to nausea and vomiting. So this is one thing that happens because of the increased content and bowel distension. Its natural tendency of the bowel to start its peristaltic movement. So that's why it will increase the contraction, because they want to get the contents out of the bowel, which will lead to colic. And because of the distension, there will be continuous abdominal pain, which is not colicky as well. So there is continuous pain as well and colic as well. Again, the distension will, as we said, kind of disrupt the normal intestinal epithelium because of the hypertensive state, which again leads to increased in the inflammatory response and secretions of various prostaglandins and nociceptive mediators, which lead to wall edema, again leading to increased secretions of water and sodium and chloride. So it's a vicious cycle which has to be broken at various places if we need to manage these. Next slide, please. So the treatment goes by either if it is reversible, which has a slightly better prognosis, or irreversible. So in irreversible, we'll need to see if it is surgical or non-surgical. So if it's like one level obstruction and you feel that it will help with the like surgery will resolve the like post surgery, you'll not have complications and will lead to multiple level obstructions, then surgery is the choice. But if not, then you might have to go for non-surgical management. Again, you need to see if it is partial or complete as well. Next slide, please. So just to briefly point out what is the management of bowel obstruction. It is basically you put in nasogastric tube and manage the nausea with haloperidol. It is all temporary because you need to give the gut some rest. If again, depending on if it is complete or partial, you need to prognosticate for the patient and again tell the relatives, patients and the relatives what is the prognosis and how we are going to manage it. So again, it goes with either surgery or supportive care, if it parenteral nutrition, and maybe manage medically and see if it works. And if you feel that the prognosis is not so great, then maybe just give symptomatic treatments and supportive treatment and venting gastrostomy if necessary. Next slide, please. Then these are the surgical options that we have. If it is an isolated lesions, then stenting can be done. So you can do colostomy if necessary, and decompressive interventions like we said, nasogastric tubes and venting gastrostomy, etc. can be done. Next slide, please. I think again can you go next? There are a few more things I'll completely blocked. So basically, previous one. Thank you. Sorry. Yeah. So these are the various agents that can be given for obstruction and where it will act. So prokinetic, to give or not to give. So you can consider prokinetic in partial obstruction, maybe just to kind of propel the increase the peristaltic movements and propel the stools out. Anti-secretory can be given to decrease the secretions and thus help with the nausea as well. Antiemetics for the nausea, vomiting. Analgesics for both the colon and the colic and the continuous pain, and steroids to reduce the inflammatory response that is there. Next slide. So again, so partial obstruction. So what we need to focus here on is to get the bowels to start moving and to regain its function. So anti-secretory might not be necessary here. You can just work with laxatives and prokinetics if necessary, or maybe steroids. Antiemetics need to be given because nausea is present there as well. And opioids can be given for the continuous pain that we are considering. Next slide. In complete bowel obstruction, so the goal here is completely different. We want to shut down the gut. We want to give it a complete rest so that we can help with the resolution of obstruction. So here steroids and opioids are a must, because steroids will decrease the inflammatory response and the edema, which is also an additive factor in causing obstruction. Opioids to give bowel a complete rest, because again, as we know, they are anti motility as well. So the colic will also be dealt with opioids. Anti-secretory agents to reduce the secretions and content in the colon. Antiemetics, anti-nauseants, for example, haloperidol, need to be considered, and venting gastrostomy if that is what the patient requires. Next slide. So again, an example. She is a 42-year-old female with cervical cancer, is having peritoneal carcinomatosis and admitted with small bowel obstruction. The medications that she has is metoclopramide, dexamethasone, haloperidol, and octreotide. Do you think this is a good regime for the patient? Or do you want to add something to this?
Yeah, the concurrent use of a prokinetic and an anti-secretory like octreotide, like metoclopramide and octreotide, I don't think that's rational.
Okay.
It's either one of them. So depending on whether it's a complete or a partial obstruction, we can choose either one of them.
Okay, good. Anything else you would want to add for her? Next slide, please. So opioids should be considered because there is continuous pain as well. And for colic, maybe, if she has colic, we don't have a complete history, so we don't know if she has colic, but anticholinergics or anti-secretory was also already going on, but, anticholinergics might help. And also, we might want to, I think, yeah, and metoclopramide, as you correctly said, we need to first find out if it is partial or complete. And also, even if it is partial, if there is a component of colicky pain in the patient, you would avoid any prokinetic agents. You would go for you would not do that, give that, and you will go for anti-secretory or any other medications or anticholinergics to help with the pain. Next slide, please. As we said, metoclopramide only in partial obstruction if the patient does not have any colic, and the rest of them also help with the nausea because it kind of soothes down the gut and does not lead to the emetic sensation. Next slide, please. So this is my last slide. This is just to kind of give the doses of what various drugs that we would give. Dexamethasone in the range of 6 to 16 milligrams daily. Glycopyrrolate, again, it's an anti-secretory agent, and an anti motility also. So that will help with the secretions as well. We generally give Buscopan or hyoscine for our setting. So glycopyrrolate, if it's frequently used in your hospital, that's fair enough. Octreotide, it's usually in the dose in the range of 0.2 to 0.9 milligrams per day, subcut or IV. So the controversy here is that the half-life, they say that you can give it Q8 hourly, but the controversy is that the half-life of octreotide is 6 hours. So either you give it 6 hourly or you give continuous infusion of octreotide for optimal benefits. Otherwise, it loses its efficacy. But in my own experience, the patients have benefited with 8 hourly subcute injections as well. So you might have to kind of titrate it according to the needs of the patient in your setting. And metoclopramide, again, in partial obstruction with no colic for nausea, and for as an prokinetic agent as well. So before I end this, can someone just tell me if you have a patient with, let's say, complete bowel obstruction? He's a case of, let's say, CA colon itself. It's a CA colon patient with complete obstruction since 5 days. There are multiple air fluid levels on X-ray. The patient is complaining of nausea, vomiting, abdominal distension, colic. Colic has decreased since last couple of days. Let's say 2-3 days it has reduced, but previously it was there. And not passing flatus, no stools, as I said, complete obstruction. What would be your regimen for him? There is abdominal pain, but colic not so much anymore. So what would you give in this patient?
It would be a case of perforation, I think, post-obstruction.
It's not perforation. He's not having any tenderness or guarding or rigidity. It's not perforation, it's just obstruction. Anyone? So this is the list, and what from this list and what else with it. Suppose that it comes to your OPD or in your referred from ward, how would you try and manage it?
See, unless the source, unless the real problem is sorted out, if you give these medications, would it help? The only thing from this which we can select is probably dexamethasone to reduce the edema. Otherwise, it is important that we have to sort out the problem of obstruction.
Suppose the patient is best supportive care. The patient is not on any active treatment. He's post chemotherapy, he's post surgery also, and he's post radiation. There is nothing more you can do. He's just for best supportive care now, but he's having all these symptoms and you need to give him medications. What will be your line of management? As you correctly said, dexamethasone for the edema, yes, along with that, because only dexamethasone will not help. So what else can you give?
There are responses like colostomy, enema.
Multiple level. Let's say it's a multiple level bowel obstruction and colostomy is not feasible. Enema you can try, but since it's an obstruction, it's not like you will not be resolved completely. Like then, supposing if there are any stool contents distal to the obstruction, then enema will just remove that, but nothing else. So what else?
Then antisecretory can be given. Octreotide.
Antisecretory, yes. Okay. Supposing you start off with octreotide around, let's say, 100 micrograms or 200 micrograms Q8 hourly. Okay. Or 6 hourly, depending. So dexamethasone and octreotide. What else? He's having colic, occasional colic, continuous pain in the abdomen, nausea. Stimulants, I don't think so. It's already having colic and it's complete obstruction. You know that it's complete obstruction. So I don't think stimulants will help. So can you go 3 slides up? One more.
There are a few more charts like opioids for pain, anticholinergic and parenteral nutrition.
Right. So, anticholinergics will help for the colic. Opioids, yes, because it is complete obstruction, you have to give opioids. So it's a big myth that you cannot give opioids because it will further increase the constipation and lead to malignant obstruction. No, here you need to give it for the pain and to kind of give the gut a rest. That's what we want in a complete obstruction. So opioids, even morphine can be given, but if you're not comfortable with morphine, you can apply a fentanyl patch or a buprenorphine patch also. That's completely fine. Parenteral nutrition, yes, to support the patient nutritionally. Yes, parenteral nutrition can be given. Opioids, anti-secretory, that is anticholinergics, yes. Any other antiemetics you would want to give, or would what will be your antiemetic of choice here? Do we give just opioids or opioids? You don't want to give methyl naltrexone here because again, what happens is that it can further lead to colic here if you kind of completely take away the effects of opioids in these patients in the gut lumen. So what methyl naltrexone is, basically it's a peripherally acting mu agonist, right? So what happens is that will act on only maybe very effective for as an antagonist in the gut mu receptors. So not here, not if it was opioid induced constipation, then methyl naltrexone would work wonders. Dexamethasone will act as an antiemetic as well. Yes, haloperidol, yes, because it's centrally acting and will help with the nausea. Exactly. So again, just briefly, so what exactly would you give in this patient? You would give anti-inflammatory, that is dexamethasone, which will again act as an antiemetic as well. Opioids for the pain, for continuous pain, yes, because of its effect on the mu receptors in the gut, it will help reduce the motility, thus helping with the colic. So some effect on the colic as well. Anti-secretory agents, that is octreotide, to reduce the secretions. Again, the dose will depend on the patient and how you titrate it. Antiemetics is haloperidol or even 5-HT3 ondansetron is also fine. Again, it will have an effect in giving the bowel rest as well. So that is also fine. Anticholinergics for the colics, and we forgot NG tube to just remove the excess secretions that are already present in the stomach, to just kind of again give it a rest, the bowel a rest. Okay, I think that's it from my side. If anything else, if you have any doubts or if you want to clarify anything, please.
Dr. Rutula, I would like you to comment a little bit on the parenteral nutrition, like how that's often the question or the dilemma that we see from when we get referrals. They'll be usually on many
Right.
parental. So just would
Right.
like to have a discussion on that.
So parenteral nutrition in a patient with good prognosis, like if it is surgically manageable, and then that should be given to the patient. That is not an option, because even if it's a complete obstruction, or it's usually a complete obstruction when you'll give parenteral nutrition, but it has to be given if it is a good prognosis. If it is a moderate prognosis where you might want to try, where the life expectancies maybe in months, again it can be offered to the patient or the relatives. Because usually parenteral nutrition is kind of expensive here, and I'm talking about TPN and all those high protein and high lipid infusions which are given, so they are kind of expensive. So you need to see the finances also. That financial part also comes in a great deal here. So I would personally give it for patients who have either very good prognosis or life expectancy is in months instead of weeks or days. Then I think it is fair enough to offer it to them, and if they want, they can go for it. If the prognosis is not so good, and you're maybe few weeks or few days, then I don't feel that there is any point in starting the parenteral nutrition, because it again has its own complications with dyselectrolemias, and it's invasive and all sorts of things. So and it is not going to change the prognosis or the outcome. In fact, it might lead to prolongation of the suffering. So not in patients who have bad or poor prognosis, but in patients with good prognosis or even moderate prognosis, it can be considered. Yes, Sharon ma'am, you have a question.
Yes, this is regarding, I think, the case scenario, the first case scenario you had presented regarding that patient with gastric cancer who had intractable constipation. Yeah, in his case, would there be any, would it be helpful to switch opioids, like from, instead of morphine, switching over to transdermal fentanyl? Is that,
that is an option. Again, so common misconception that fentanyl will not cause constipation. It is just that it, because it is not given orally, it kind of it does not have that much of an effect on the gut mu receptors. So it is not completely that it will not cause constipation, though it is helpful because it is less constipating in general. So yes, switching it over to fentanyl will help, but since the mu receptors are already blocked because of morphine, methyl naltrexone would be a better option, because it will just kind of remove the effect of morphine there. NG tube in these patients, is it viable? Yes. So what it does is basically it removes the excess secretions in the stomach. And you're talking about NG tube aspiration. You're not just talking about just inserting an NG tube and keeping it.
No, ma'am. I want to know about NG tube feed, like feed. Since we were talking about nutrition in these patients, we were talking about parenteral nutrition. So parenteral nutrition can be total parenteral nutrition, or it can be enteral nutrition by inserting a nasogastric tube, right? So is there an option where the nasogastric tube can be used for nutrition as well?
No, you have these patients when either partial or complete obstruction. In these patients, you would not want to give anything orally. So it's nil by mouth. You're not giving anything. until the patient starts passing stools or flatus. Then you can start off with, sips of water and for a couple of days, or, clear fluids, like you've strained all of them and given them. So soups or juices or anything, but again, clear fluids. Then you proceed to soft solids, maybe, khichdi or something, dalia types, something which is very soft and easily digestible. And I would stick till that. I would not go to solid food, because there's a chance that he or she might land up in obstruction again. So I would just stay with the soft food. So, but NG feed, no. And the NG tube is for, removing all the secretions that are already there, and to reduce the distension and everything. With I think it'll only increase intraluminal pressure with the decreased motility. No, so it's kind of the opposite. It will reduce the intraluminal pressure because it is removing all the secretions, right? So you're on continuous NG tube aspiration. So there is like a Euro bag attached to the NG tube, and it is continuously draining whatever secretions are there in the stomach. So this actually helps with the nausea itself, because all the secretions are out, and that there's no more you meant the feeding. Yeah, feeding will increase the pressure. Yes. Discomfort of tube in the nose. I think here the discomfort of the tube in the nose outweighs the opposite, like the nausea and the distress because of the abdominal distension is more than the distress because of the tube. Then that will be a venting gastrostomy. It will not be a feeding gastrostomy. But again, that is more invasive. Like, why would you want to go for a more invasive procedure in patients who have like maybe 2 weeks of life? I hope I was clear. I mean, there were very like a lot of disturbances, and I kind of prepared it in a hurry. So I'm not sure if I was clear enough for you guys.
Yeah, after the, I think the second half, like where you got some network, then it was uninterrupted from there.
Thank you.
Any other questions? Today, we do not have a case presentation, unfortunately, because the presentation was not matching the topic for today's discussions.
Oh, okay.
We may not have a case presentation today. We may have to, so those who have not sent the presentations, kindly send it. Otherwise, we'll miss many discussions if you don't have, and case presentations are mandatory for all our sessions. So those who have not sent it yet, please, most of you have, but some of you have not sent it yet. So please kindly send in your presentations as soon as possible. If there are no other questions, then maybe we can wind up. And thank you so much. I should mention that the faculty who was supposed to take session fell ill the last moment. So we had to literally bother Dr. Rutula at the last moment. That's why she is in hospital, and